So step 1 of the protocol wasn't the solution for your patient. We've now moved to step 2. Now in step 1, we had tape and a nasal dilator. In step 2, we're going to add to that. So we'll have tape, nasal dilator, and a mandibular night guard. Now that night guard is going to be made in a provisional manner because we don't know if that's the right appliance for this particular patient. Once you've delivered the temporary appliance to the patient, you're going to give them 2 to 3 days to see how they react to it before you give them a call and see what the response happens to be. At this step, we actually in my office have them sign an informed consent for all the appliances used in the Seattle protocol. What's the informed consent deal with? Well, a couple of our appliances are going to protrude the mandible forward. And so there is a risk associated with that. If the patient goes away, continues to use the appliance indefinitely, that we can alter the bite. So that's what they're signing for.
So our patient has failed step 1 of the protocol. If the patient fails the step, we actually need to send them to an otolaryngologist or an allergist to make sure that they can breathe through their nose correctly. If they like step 1 of the protocol, then what they're saying is there's something that was creating a flow limitation and we've got to figure out what it is. So the control strategy was keep on the tape, keep on the mute dilator, but why don't we see an ENT, why don't we see an orthodontist, why don't we see a myofunctional therapist, look around their mouth to try to get clues as to why it required tape and a dilator to make them sleep better. The third way that they can react to step 1 of the protocol is they actually say, you know, I can do that, but it's not making me any better. So as soon as they say that they're not satisfied with step 1 of the protocol and not getting a better night's sleep, we actually move on to step 2. In step 2 of the protocol, we're going to make them a mandibular night guard. Now there are 2 things you need in step 2 of the protocol. You need a mouth mirror, and mirrors are really important. And we're going to be working in the mouth, we're going to be working with an irradiated thermoplastic material that will bend and deflect and change. So you've got to get their cheeks out of the way when you're working in the mouth. So when you're using a mouth mirror in the patient, you really want to use that as a retractor. We too many times start using our finger as a retractor and it takes up too much space in the mouth. It's important, given the deflection of the material we're going to use, that we have as much room as possible to work, especially in a constricted arch like what we have in our patient today. So mirror is going to be important. The other thing that you need in step 2 of the protocol is actually the MyTap appliance. MyTap appliance is going to come in a bag like this. What you're going to find inside the bag are many things that you're going to want to utilize later on in steps 4, 5, and 6 of the protocol. You're going to get what we call an AM aligner. AM aligners are used to regain bites when they wake up in the morning and they're having difficulty finding their bite in the morning. The next thing is a mouth shield. A mouth shield will be used once again at steps 4, 5, and 6 of the protocol. It will become obvious later on as there is a small stick that's going to be extruding past their lips. Because of that stick, it's going to be difficult for people to actually close their lips around the appliance. This mouth shield is going to help them continue the idea from step 1, which is they need to be able to breathe through their nose. You'll get instructions for use and how to fit them. And the last thing you're going to get is actually the appliance itself. Inside the box there will be the appliance, and there are 3 parts to the appliance. There's the upper member of the appliance, the lower member of the appliance, and a little screw that's going to be used to actually protrude the lower arch. Now, the original design of this appliance was it was going to be used as a sleep appliance, so upper, lower, with a lot of protrusion of the lower jaw. If a patient came into your practice and they complained about snoring and they needed that type of appliance, you could immediately open this bag, make them an appliance, and they could go home that night. Or if a patient had a sleep appliance and it broke and they needed to send it out to the lab, they didn't have to go without an appliance and be unhealthy for a while. So that's what the original design was. I'm going to modify that design to actually turn it into all 5 of the different kind of night guard categories that a dentist can make. So 5 different devices from a single device. For steps 2 and 3, we're we're going to be focused on using the lower member, which is the one that has the stick extruding from it. So take the upper, take the little screw, and we're actually going to place that inside the patient's box for safekeeping. So the mouth shield, the AM aligner, upper, and the screw are going to be placed aside. All we need for step 2 is the lower member of the MyTap. Now, it's made of a radiated thermoplastic material, which means that when you heat it up, it actually is going to get really soft. And it's going to get soft in all dimensions, meaning if you've got a big arch, you can push it out there. If you've got a really constricted arch, you can do that. If you've got missing teeth, you can actually mold it around and change it around those teeth. Or any kind of dental situation you might run into can be dealt with this appliance. Before I start heating it up and moving it around, I want to visualize what changes I might need to make. So I'm going to take it before it's ever been heated, place it in the patient's mouth, and see in advance what changes I might need. In this patient's mouth, it extends quite deep. I know that's difficult to see, but the arch is very small. The appliance is longer than the arch itself. So what it tells me is I'm going to need to actually be trimming away on the back. While it's molding, I'll be pushing there to try to keep it down around the second molars. So I now know what changes I'm going to be needing to make as I go to her mouth. Many times we end up having to open it up because the arches are larger. The other thing that's important about the MyTap and the way it works so beautifully in turning into other appliances is that the top of it, when you look at where the biting surfaces will be against the maxillary teeth, that's actually hard acrylic as opposed to soft thermoplastic acrylic on the inside. So our occlusal splint, our mandibular night guard, will actually have a hard place for the maxillary teeth to land. Now how do we modify it? Well, we've got to get it warm. So we place it in a bowl. We're actually going to be pouring hot water in. I need it 100 to 60 degrees or greater. So how do we go about doing that? In my practice, I actually have a hot water bath, but many of you won't. So an Insta-Hot in the office will work. Microwaving water works, although when the water starts to cool down, you're going to have more difficulty getting it to actually transform into the condition that allows it to be molded. You can also get some sort of percolator to keep in the operatory during this particular type of event. Okay, so we've got our MyTap appliance in a bowl. We're going to pour hot water on top of it. And as we do that, you'll start to notice that it turns clear. Now I need the entire appliance to actually be clear so that it's moldable around the teeth. When I go into the mouth, I'm going to be inserting it with light pressure, and I'll then tell the patient to bite medium hard on it. Patients that tend to bite too hard on it will sink their teeth into the thermoplastic material. The material will rapidly cool around them, and they'll complain later that it's very tender on their teeth. It feels tight to their teeth because this material actually continues to set over quite some time. So the thermoplastic material is quickly getting clear. We agitate it the last bit to get it completely clear, and now we're ready to go to the mouth. Now a lot of times when it gets clear like this, people rush to the mouth and feel like they have to get there quickly. You actually have quite a bit of time before it transforms from this state. So take your time, adjust it the way that you need to at this point. If you need to expand it, you can pull on it and expand it. Remember, we're going to be pushing down where the second molars are. All you want to do is align the stick along the midline of the patient, seat it around the teeth lightly, and then have the patient bite medium hard into their maximum intercuspation bite. Pay attention to make sure the material is not folded as you put it in. And then have the patient close around the stick and suck against the stick. In the past, what we would do is after the first minute of the initial set, we'd ask the patient to rub on their face and push it in place. We'd also ask them to aggressively push with their tongue to mold it around the lingual surfaces. Today, I think actually just sucking against it does a fine job. The most difficult part on doing the lower is the lingual. And when patients that have airway issues in particular, or tongue ties, when the floor of the mouth rises or they try to protect their airway, it'll actually fold the lingual under and start getting it pushed onto the occlusal surfaces of the teeth. And then the fit isn't quite as good. So I don't tell them anything about their tongue. I don't ask them to do anything with their tongue. The only time I mention their tongue is if they have a lingual retainer, an orthodontic retainer. I tell them not to push it with their tongue under the retainer, because we've caught it under that retainer, and actually I removed one time, and many times you start breaking out in a little sweat when it gets stuck on it. If, by the way, it does get stuck, just pour some warm water in their mouth, have them hold it, it'll soften enough to come out easily. The initial set takes a minute. We want to remind the patient to continue to close and kind of suck against it. The final set is 3 additional minutes. So 4 minutes total at this point in time is what we're waiting until we can actually remove the appliance. So the goal of step 2 of the protocol is actually to produce a mandibular night guard. And now that you can see that we've removed the lower MiTap, it looks like a lower night guard. Some of you are familiar with harder outside shells of night guards with softer material on the inside. That's essentially what this is. The only difference between the night guard you're familiar with and what we're seeing right now is this one's got a stick hanging out. And that's really not acceptable for a lower night guard. We've got to get rid of the stick. So the laboratory procedure that has to happen in step 2 is to remove the stick. Now there are a lot of ways of getting the stick out. You can wedge it out like a wishbone on a turkey, but all the ways that I've seen to get them out never allows you to get the stick back in, because we need to do that for steps 4, 5, and 6. So we've got to be able to get the stick out of the lower night guard in such a way as to be able to return the stick if the patient needs us to actually protrude the mandible further on in the protocol. So the way that Dr. Kinzer and I figured out to do this is you actually go to the internal surface, and we're going to make 3 cuts. So there are 2 things that you need in the laboratory. The first thing you need in the laboratory is actually a barred Parker knife, some sort of laboratory or surgical knife that is a 25 blade. The other thing you need is a lab knife. Buffalo knife is a common name for that. It's not going to be as sharp. What we're going to use that for is to wedge the little bit of thermoplastic free. So the first knife that's needed is our surgical knife, and we're going to be making 3 cuts. We're going to make it on the inside thermoplastic material. And what we'll do is actually figure out how wide is the stick. And we need to make our internal cuts just wider than the stick. So pay attention to the width as you turn it over and begin making your first cut. So the first cut will be a vertical cut, and the vertical cut simply goes halfway through the material. The second vertical cut is on the opposite side of the stick, once again, just halfway through the thermoplastic material. Now we've got to connect those 2 cuts now. So the third cut is actually going to be a connecting cut that's made. So we put our blade in and actually begin to connect those 2 cuts. Now the most important part of this is safety. And if you watch, all the cuts are going to be made in such a way as if the blade slips at all, it's going to slip into the desk. We never want to actually pull the knife towards us at all. So all cuts are made in such a way as to push towards the desk. So if it releases at all, you end up going into the desk, pushing into the desk and not pushing into your fingers. So please pay attention to that. This should not be a difficult procedure to do, one that you feel that the knife is actually going to slip towards you. Okay? refine those cuts, kind of deepen the cuts. Now we're not cutting all the way through the appliance. All we're working on is being able to actually wedge out this little piece of thermoplastic material right here that's covering over the top of the stick. And we'll refine the third cut. Now what I have found is that in a moment I'm going to try to wedge that little piece of thermoplastic material out. And the cuts will not connect. We'll get a little bit of it, especially right in the corners here, that are still connected. And we'll have to go back in again with our surgical knife. So we set the surgical knife down. Never take the surgical knife and actually start wedging with it, because you will slip and hit your finger if you do that. Take this laboratory knife to begin doing any kind of wedging or movement, any kind of force that's being applied. We want it applied with a laboratory knife. It's a much safer way of doing it. And you can see how we're trying to tease up this little piece of thermoplastic material. And we'll see in a moment that in fact the connection point of our stick is just right below it. So, as I said before, typically as I wedge these free, I realize that I haven't made it all the way through with my cuts, and we'll refine the cuts here in just a second as I've completed the wedging. Now, you're already getting a clue. That's the connection point right below where that piece of thermoplastic material is. You can see where the stick actually connects. So let's go back to our surgical blade. Let's make some connecting cuts that actually will free the little piece. And now you can see how the stick actually attaches to the MyTap. All it takes now is a simple move and the stick is free. So at the end of this laboratory procedure, what you should see is the stick, the actual appliance itself, and a small piece of thermoplastic material. Pay attention to this one spot right here. It's a little bar that actually the stick is going to reattach to. So we want to make sure that's preserved, because the stick will reattach to that in steps 4, 5, and 6. Now I also told you that in our patient that we're treating today, that the thermoplastic material is long. And you can see it going well beyond the second molars. Now I've tried using acrylic burrs on thermoplastic material my entire career, and all it seems to do is melt it and create little strings that come off. I find the best way to actually trim excess is using, once again, a surgical blade, not the laboratory blade. The lab blade can get through it, but you end up having to sort of gnaw and really work hard, way too hard. Surgical blade is what you want to use here. It makes a clean cut. What direction do we cut? We always cut so if you happen to release the blade, it ends up going into the table. So focus on pushing deep into the table and get through the thermoplastic material. Just a quick rule of thumb. If you're going to cut anything, we're doing it with a surgical blade. If you're actually going to try to wedge anything free, that's where the laboratory knife comes in handy. Another rule of thumb is if the surgical blade, or Bard Parker blade would be another name that's will be used in your office, if this feels like it starts to drag in the material at all, please replace the blade. So if you're not getting a clean cut and it's going through easily, replace the blade immediately, and you'll find it much simpler to finish the cut. Okay, so we just lightly round off some of the edges so the patient's more comfortable. And I'm doing that with the blade, and you notice as I'm doing it, I'm pushing it where it releases into the tabletop. It's not going to actually take any chance of harming me at all. Okay, now we'll do the other side. So I did that one from the inside. You can actually do it from the outside as well. So you can push down into the tabletop, simply cut it through. Any little sharp edges, take the blade and push towards the tabletop in order to trim the edges away. So, now that we've gotten the stick free, you can see it looks more like a mandibular night guard that might have returned from a laboratory. We have hard acrylic on top that we can actually adjust the occlusion if we feel it's necessary. We have softer material that's going to mold around the teeth and hold it in quite comfortably for the patient tonight. As with any mandibular night guard, you're going to want to adjust the occlusion. With this one, if you choose to adjust eccentric relation using a leaf gauge or whatever technique is comfortable with, you can do that. In our office, we simply find a maximum intercuspation bite. We know this is a short-term use appliance, and so we're simply going to try to adjust where we get bilateral simultaneity of the contact, nice contacts all throughout the arch. What we're looking for here is what is the increase in vertical dimension going to do for this patient's sleep? Can you remove the appliance for me? Thank you. So we'll make a few adjustments to the appliance. Let's try that back in. Good, we're almost there. One more adjustment. The nice thing about this is it's self-equilibrating. As the patient bites down into it, tends to seat it over the teeth and get pretty close to where you want before you even begin the adjustment process. Good. Good. Open for me. Take it out. Thanks. All right, so we've got simultaneity of contacts. We have it throughout the arch. Now what do you do with this appliance? You send the patient home. They're going to be wearing it tonight. What else are they wearing? They're continuing the taping and dilator that we used in step 1. So we're building on to step 1. Step 1 didn't fix them. They could do it, but it didn't make them better. Now step 2 is saying, what if we open their vertical dimensions slightly and give them a little more room in the mouth? Well, how are they going to react to that? What we'll do is call them 2 to 3 days later and ask them for a subjective impression of their sleep. If their answer is, I'm sleeping better, then we give them 1 more week just to check out and make sure that it actually continues the effect. At the end of a week, if they're continuing to sleep better, then we'll send them home with a screening tool, the same one we did before, high-resolution pulse oximeter or a cardiopulmonary coupling unit, whichever one they used as a baseline screening tool. If that shows that the airway seems to be better at night by simply making an occlusal device, then what do you do for a control strategy? You take this provisional device and turn it into a final device. So the way I would recommend handling it is I would take some adhesive and place it on the device. I would put the device in the patient's mouth and inject bite registration material on it. After the bite registration material sets, then I'd remove the device with the bite registration intact, make impressions of her upper teeth, her lower teeth, send all 3 of those things to the laboratory. Now my tap provisional appliance is acting as my bite registration, showing the lab the exact vertical dimension that I'd like to work at with the final prosthesis. What would I make? Well, the lower seemed to work for the patient. Why not make another lower? But if you're more comfortable with an upper, go ahead and do that. Just work at that vertical dimension. If your idea of a night guard is more anterior, then do that. This vertical dimension, I think, is the most important part of it.
So you've seen how to create the provisional mandibular night guard with the patient. Remember, they're wearing it with a piece of tape, nasal dilator, and the night guard. Once you've called them in 2 to 3 days, if they have a positive response, what do? Well, you actually wait another 7 days and call them again. Remember, we see how they're reacting and then give them time to verify that that actually is their true reaction. If it is, at the end of 7 days, you send them home with screening tools to verify subjectively and objectively that the mandibular night guard happens to work. So if we get both subjective and objective positive responses, what are we going to do? You're going to make them a night guard. So in your practice, if you happen to be using an upper full arch night guard, that may work. If you use a lower, that's awesome because you've already proven that it worked. Or if you use something more anterior, that can work as well in many of these patients. What we know is by opening the vertical dimension with a piece of tape and a dilator, we are having success. Let's make that final appliance for this particular patient. What's next? What's next is you want to take the piece of plastic back if at all possible. So what your doctor is going to do at this point is they're going to say, what did that tell me the patient needs? Now, many of you that have been doing dentistry a while will remember there was a point in time that whenever we were going to open the vertical dimension on a patient and do a full mouth rehabilitation, we always began by making them a night guard. We said we want to see if they could tolerate the opening in vertical dimension. Well, in fact, this step of the protocol just proved that they love the opening of the vertical dimension. Maybe if the patient needs a rehabilitation, that's the dimension you work at. How about orthodontics? Can that open vertical dimension? Absolutely it can. But you're also going to be looking around the mouth for other clues. Are they tongue-tied? Do they have a weight problem? Do they need nutrition counseling? Do they have a nasal problem that needs to be addressed? Or maybe a soft palate problem where they need tonsils removed or soft palatal tissue removed in the back of the throat to actually be able to breathe more effectively. The Seattle protocol and a positive response to step 2 doesn't stop there. It always leads to the effort to resolve the problem long term.